So the eggs are really what matter most for age. We know that we have a set number of eggs that we are born with, and that we start losing them right away. So when you're born, you have, a couple million, and then by the time you reach puberty, you have even less, maybe 300 or 400,000. And so you're starting to lose them before you're actually even having periods. And then once you're having periods, you continue to lose them, and you lose them every month. You're always losing them, unfortunately. And so that's why as women get older, you have less numbers of eggs overall, and the quality is also less too. Unfortunately, the quality is not necessarily something that we can check. We can check numbers by doing ultrasounds and things like that, but we can't check the quality. So we always extrapolate that based on age. And so this is a nice slide. Oh, actually, can you go back? Sorry. This is a nice slide that kind of breaks it down. So you can see in gray the number of eggs that you have, and then yellow, that's your birth rate. So the egg number goes down, and there's a more precipitous decline in the mid to late 30s. And then the chance of pregnancy also goes down. Because this is being proactive, I also think it's important to note that even when you're young and you're in your most fertile time, you're never 100% chance of pregnancy. At most, you're maybe about 20% or so, but it really does go down as you get older. So as you're planning, as you're looking ahead, you just want to kind of keep this in mind. It's not like it is in health class or whatever they taught you in high school where everyone just gets pregnant like that. It's a little bit more challenging. So kind of going back to age and thinking about all of that, the number 35 is something that you'll hear a lot. Doctors point to it a lot as the time point at which fertility declines, but it's not a light switch. It's not like one day it's on, the next day it's off. As I mentioned, all the eggs we've had forever. They get older with us as we get older, and so they just aren't as good anymore. And so we know that it's common for women to become infertile or have more difficulties or challenges as they get older, but even younger women can have issues too. So about 1 in 10 of women have premature or like low ovarian reserve, even under 35. So that's why it's important to get tested, be proactive, get knowledge so that you can know this ahead of time and then be prepared. So again, both quality and quantity matter. Both of those go down as we get older. And when I say quality, I kind of mean, the genetics of the egg. So that can lead to miscarriages or not getting pregnant. There can be chromosomal or genetic abnormalities if it does result. But those are really important factors that you want to kind of think about now. We have ways that we can intervene now. For example, freezing your eggs, for example, is awesome because we can preserve where you're at now and you can use them down the road. It doesn't mean that you are or are not fertile, but we just save it where you're at right now. So again, being proactive, being here, you're doing all the right things. As far as kind of the actual testing that we do, we evaluate what's called your ovarian reserve with 2 kind of simple basic tests. So the first one is an internal or a vaginal ultrasound. That's the best way to visualize the ovaries. And so we do an ultrasound, we can look at your uterus, and we really can focus on your ovaries, counting the follicles, which are little black circles that we can see on ultrasound that house the microscopic egg inside. So we can count it up, we can see how many you have in a given month. Usually that's kind of where your body normally is, plus or minus a little bit. And it gives us a sense of just your resting egg count. In addition to that, we also will do blood work for hormonal testing. And there's a very common blood work that we do called an AMH level, or an anti-Mullerian hormone. And that is also another way that we can just see kind of what your resting follicle count is like and how likely you are to respond to medication. So doing these tests, again, we get information, we can kind of counsel you, tell you what it means, and maybe give some recommendations on where you're at kind of in relation to other people your age, if your numbers are low or high or what, but we never know what these are until you do the tests. So we definitely recommend getting checked out. Again, so the quality is what we can test. We cannot test for quality. Quality is based on your age. But when you do these sorts of tests, and with Kindbody, we're really big, as I said, in the patient experience. We have a wonderful portal. And so this is actually what your results will look like in your portal. So it's a nice example of what your AMH level is, which again is the blood test kind of that tells us your resting follicle count as a marker, if you will. I kind of liken it to a gas gauge where you can kind of see if you're on the high side, the low side, or kind of in the middle. And then your antral follicle count, or sometimes it's abbreviated AFC, that's your resting follicle count that we get from the ultrasound. So you can see it really nicely is laid out here. And you can see the levels. We have fertility calculators and other things that we can tell you about as we go through the Kind Body journey. But there's different ways that we can kind of tell you what this all means. And then of course you would meet with the doctor or talk to the doctor about your results too. And again, this is only for quantity, not quality. The second next important part for you to take home is that there are certain gynecologic conditions that can impact fertility as well. So making sure that you are aware of this and aware of your body is important. So one of the first kind of umbrella categories is ovulatory dysfunction. So that is just essentially anything that could cause you to not ovulate or release an egg regularly. You may or may not know if you have these, but just so you've heard of the topics or they sound somewhat familiar, you can go look them up further. There's something called PCOS or polycystic ovary syndrome. And that's where there's a hormonal imbalance and the egg doesn't get released every month. So in this case, it does become hard to get pregnant because you're not releasing an egg. It's hard to time intercourse when the sperm and egg get together. In addition to that, you can have hormonal issues that lead to irregular ovulation. So your thyroid is important, another hormone called prolactin. If these are in an abnormal range, it can lead to ovulatory dysfunction. There's also another category called hypo is kind of the short version, but it's hypothalamic dysfunction that can be resulting from a variety of different things. So excessive exercise can lead to it, very low body weight, if there's eating disorders, anything that kind of disrupts the normal hormonal axis that causes ovulation to occur can lead to obviously difficulty ovulating and infertility. And then there's another category called ovarian failure, or POI is the short version for primary ovarian insufficiency. And this is kind of like an early menopause. It's not necessarily that the ovaries don't function at all. There are some cases where you can resume ovulations, but this is usually a very kind of uphill battle. And if you're not getting periods and you're diagnosed with this, then there are certain kind of other ways that we may recommend treatment for you to be more effective. But again, knowledge is power. If you don't do the testing, you don't know. And so getting some tests done can help you get guidance as to where you stand. Again, going back to the uterus as one of those building blocks. So the uterus is important because it houses the pregnancy. And there can be different things that can impact your uterus. And if there's any sort of potential, something in the way that would cause an embryo not to take, we would want to address that. And so there's different types of ways that this can be addressed. And you may not even know you have anything wrong until you do some testing. The tubes are important because that's where the egg and the sperm meet. But the uterus is also important because if an embryo decides it wants to implant, but it implants on something called a fibroid, which is kind of a benign little growth of cells, then that is not a normal place for it to grow. It doesn't have a normal blood supply and it decreases your chance of a pregnancy. So fibroids are very, very common. Again, they can be located at various different places in the uterus. Sometimes they matter more than others. And so again, getting the evaluation, learning about it, learning about just your general health. And then if it is something that could be impactful for fertility would be good to know. And so we do this with something called a saline ultrasound. We can also do something called a hysteroscopy or a HSG or hysterosalpingogram. So we have a variety of tests and whatever is best for you can be discussed later. But essentially we're looking for a couple different conditions like polyps and fibroids and things like that. Endometriosis is another gynecologic condition that can be impactful for fertility. So endometriosis is a condition that many women will have very painful periods or painful intercourse, pain with defecation. And it's a condition where tissue that's similar to the inside lining part of the uterus grows outside of the uterus. And so often that's in the ovaries, the fallopian tubes, in the pelvis. It can cause scarring and inflammation. And so it can really cause a lot of potentially tubal damage and inflammation that makes it harder to get pregnant. And so if you think maybe you have this, if you do have this, you may want to consider, getting checked out sooner or talking to your doctor because it may be more challenging if your tube is blocked or if you have this condition that we know does lead to infertility. Going back to the fallopian tubes, tubal dysfunction is something that can be caused. Sometimes we don't know that we have it. Sometimes maybe there was a underlying infection or pelvic inflammatory disease. If there's any sort of reason that there's been any inflammation or any reason that scar tissue could form in the uterus, in the pelvis, it can cause the tubes to be blocked. And the tubes can become swollen and filled with fluid, and that can decrease your chance of pregnancy. And again, endometriosis can cause it. We would want to check for these things using an HSG or doing a saline ultrasound with a bubble study, which is another specific way to look at the fallopian tubes. And I know I'm going through a lot of different stuff and there's a lot of different factors, and this isn't meant for you guys to know everything always. Your doctor is definitely going to help guide you through these steps. But again, this is just to kind of be proactive and learn about this. Another thing that can be impactful is an abnormal shape of the uterus. So normally your uterus, there's not a picture of a normal uterus here, but it kind of is a triangular shape. And you can see in these pictures, none of them have that. And so you can have what's something called a septum or a septate uterus. And that's where there's a little band of tissue up at the top that kind of pokes into the uterus. And again, makes it hard for a normal embryo to implant and establish a blood connection and have a pregnancy. Another condition is called Asherman syndrome. And that's where there are little kind of scar tissues that form inside of the uterus. And that also can prevent a pregnancy from taking and resulting in a healthy pregnancy. Both of these are things that we can look at. We can repair surgically and optimize things. There's also something called a bicornuate uterus, which is a little bit of a different condition. And that's where there's kind of two horns of the uterus. So it's kind of a heart-shaped thing. And that can also lead to difficulties with pregnancy, getting pregnant, staying pregnant, for example. Number 3 thing to take home is lifestyle. So that is another important thing to keep in mind as you're being proactive as well. Of course, it's always good to be your healthiest best self. We recommend that for daily life and, trying to be as healthy as possible, eating a good diet, maintaining, a healthy body weight, all of that. Also, your family history is important. So making sure that, if your mom went through menopause early, then that's one of your more likely predictors of when you might go through menopause. So talk to your family, find out if they had issues with pregnancies or miscarriages or whatever may be the case, because that could matter for you too. And lastly, mental health is important. I am a big proponent of making sure not only are you in your physically best state of health, but mentally, emotionally, all of these things really come into play and interact together. So kind of just being in tune with yourself in all of these different areas is really important. Also, of course, smoking, obviously you don't want to do that. We want to avoid alcohol, cannabis as well. Extremes of body weight are important. Like I said, that can lead to ovulatory dysfunction. So making sure you're a healthy body weight, and making sure all your medical conditions are under control and you're getting treatment for them. So you can do, preconception check-ins or counselings and things like that. So just making sure if you do, for example, have high blood pressure, making sure your levels are good, making sure that your medication that you're taking is safe for pregnancy. So I think it's always a good idea to just check in and make sure that all of these lifestyle things are where they need to be, in addition to all of the gynecologic and your ovaries and your uterus and all those types of things too. And with that, I'm going to turn it over. I feel like I've been talking a lot, so I will let you have a little bit of time too, but I'll be here. I'll hop on for questions and stuff too, if you guys need anything. Thanks.
Thanks, Dr. Sundheimer. That was super helpful. I love the fact that within the kind body community, within our incredibly diverse group, we've had so many of us with our own stories about fertility preservation or being on the patient's side of things. And, when I was looking at the slide deck, I sort of chuckled and I said, gosh, I wish this had been available to, us X number of years ago. So I'm really grateful that we all have an opportunity to connect and, to really talk about this. And so what can we do, right? I mean, being proactive about fertility, what is it that we can do? And one of the things that, we'll commonly hear about is egg freezing. So in essence, egg freezing is a process of you get the eggs from the ovaries and you freeze the mature eggs down. The mature eggs are the ones that usually have the most reproductive potential. So those are the ones that we typically will freeze down in terms of, the egg freezing process. And why would you consider egg freezing? And, there's a wide variety of reasons, and not all of these reasons on the slides may encompass what you're going through, but it's one of these many different things. You're currently focusing on your career. You have these personal goals that you're looking to meet before you start your family. You haven't found the right partner yet. You're looking to be financially stable. You have a medical condition that affects your fertility. And you're not sure you want kids, but you have younger eggs and you'd like to have the option available to you should you one day choose to have children. So lots and lots and lots of reasons to consider egg freezing, even outside of this slide. So should you freeze your eggs, right? That's the big question. And, let's keep it simple. Let's ask ourselves 4 things. How old am I? How many kids in my ideal family? How old when I have my first child? And how old when I have my last child? So 4 things to consider when you're starting to, talk about egg freezing. And I think that sets the ground for where you need to be, how many eggs you need to freeze, and how quickly you need to get on with the process. So egg versus embryo freezing, right? I mean, all of these, we've got so many different terminologies. How do you keep it simple? So in terms of should I freeze eggs versus embryos? Again, questions to ask yourself. Do you have a partner? Do you want to be a single parent by choice? What makes you feel comfortable in terms of planning your family? What is your egg reserve or your ovarian reserve? Do you want genetic testing on your embryos or not? And typically speaking, eggs, when you freeze mature eggs down, they typically have to be thawed and inseminated or injected with sperm at a later time to create embryos. With embryo freezing, what you're doing is you're extracting eggs, you're taking these mature eggs and injecting sperm or, inseminating sperm into them. And then eventually what you do is you grow out embryos, which are thereafter frozen for future use. So that's the difference between eggs and embryos. Having said that, should, reason egg versus embryo freezing, there are so many other, things to consider as you go down this path, right? In terms of egg versus embryo. I mean, I really think, part of this is good counseling, recognizing where you are in life and recognizing the goals that you've set for yourself. I think those sort of are incredibly important when talking to your physician and having that honest one-on-one dialogue to really determine what is the best way forward, because your way forward may not be everyone's way forward, and your physician ought to be able to personalize and determine that plan for you. Next slide, please. So one of the other questions that, I get asked, and if I'm not asked, I always sort of bring this up. Look, we're freezing eggs, we're freezing embryos. Is a baby guaranteed? So not every egg will result in an embryo, not every embryo will result in a pregnancy, and not every pregnancy will result in a baby. There is no guarantee that freezing your eggs will result in a future pregnancy or baby. But in my mind, you've done everything that you could have, given, the scientific advances that we have today, to really sort of, assure yourself that, all right, you know what, at this point, I've done everything that was scientifically feasible to really visit the prospect of having a child in the future, should I choose to use these eggs or embryos. Next slide, please. So how does the process work? Let's say you decide to embark on an embryo freezing cycle. We often will start you with injections, and what we'll measure on ultrasound are things called as follicles or egg sacs. And egg sacs or follicles are easily measurable on ultrasound. Let's say someone came in during their stimulation, and by the time they were ready to go to egg retrieval, they had 12 follicles or egg sacs. When we go to egg retrieval, we retrieve eggs. And remember, the mature eggs are the ones that have the most reproductive potential. So let's say we have 10 mature eggs, which are essentially eggs that we can use. And we've injected or we've inseminated those mature eggs with sperm. Now, not every mature egg will take or meld with the sperm normally. We'd expect about 70% of them to fertilize. That's the term that we use. So about, let's say, 7 out of 10 of those mature eggs actually melded with sperm and fertilized normally. Now, not every fertilized egg will result in an embryo. I would say about 30 to 50% of the normally fertilized eggs will result in an embryo. So that would put you at about 2 to 4 embryos. Let's say you decided to, have the embryos genetically tested for common abnormalities, numerical abnormalities. Out of those 2 to 4 embryos, you could have all 4 of them normal, none of them normal, or somewhere between 1 and 3 that are normal. So, one of those, normal embryos will eventually give rise to your future offspring. So you can see that there's a little bit of funneling, if you will, and a little bit of a top-down effect. You start out with 12 follicles, and then you really get down to 1 or 2 embryos that are potentially usable and will result in a baby, which is why it's important to have these discussions and these conversations, ahead of time. Next slide, please. So what comes next? You created embryos. You're in a place where you're like, all right, I've done everything that I could. Your eggs or embryos will be stored in a cryo storage facility for as long as you want. Remember, the goal is, if you choose to, we want you to be able to conceive on your own. And if you needed these eggs or these embryos in the future, they're ready and waiting for you. Next slide, please. So what can you do to get the ball rolling? The first thing, to really sort of get a handle on where are you in life, because we're all a little bit different and a lot similar. So would be a one-on-one consultation with a fertility specialist. That's super helpful, because that helps us talk about your medical history, your family planning goals, because like I said, we're all very similar, but we're all a little bit different too. So, let's say someone with endometriosis may have different goals than someone with polycystic ovaries. And, we as your fertility specialists ought to be able to personalize your plan and next steps based on consultation. And I love that about, what we do here, that we personalize things. We sort of take into account your future goals, your current state of affairs, and how do you want to go about this? That's the beauty of what we do. And that really ought to be the plan of care for you, should you choose to do this moving forward. Next slide, please. And if you were ever looking, I saw a host of individuals from all over. Welcome, welcome, Sydney, Canada, from the United Kingdom, and from our wonderful, country here. And we're all over. And, you'll find Kindbody signature clinics. We've got 31, 32. I mean, I lose count. We've got a ton of clinics all over. We welcome you with open arms. And should you choose to ask these questions, we're excited to get started on this journey with you. Next slide. And
thank you,
Sydney.
Thank you, Dr. Pakrashi, and thank you, Dr. Sundheimer. I want to just jump in here, and we will get to Q&A shortly. I just wanted to let everyone on this event know that we do have an amazing friends and family promo happening right now in honor of National Infertility Awareness Week. So we are offering self-pay patients 20% off egg freezing, embryo banking, or IVF until the end of May. So if you were thinking about starting treatment, this would be a great time to do it. Another thing to note is that at the end of this presentation, a survey will come up on your screen. It'll ask you for your first name, last name, and phone number, and I think zip code. And that will just be to tell us you're ready to get started right away. You want to skip the line, you're ready because you came to this event. And we will have our patient care navigators call you tomorrow to book you in. So that's a really great advantage. You'll get it immediately, which is a real benefit of attending these events. Further, if you do have the Kindbody benefit, you can also activate. We'll make sure that you also get booked in right away. Obviously, this promotion is for self-pay patients, but if you have the benefit, you shouldn't need that. So very excited to have you all here, and let's get into the Q&A.